imagine going to the doctor, right? Because your hand has this slight persistent tremor. And you're sitting there, only to be told that your brain has actually been silently dying for, like, over a decade.
Yeah, it's a terrifying reality of human biology, honestly.
Right. I mean, by the time you even notice that first little shake, you've already lost something like 80% of the dopamine in your brain's movement center, which is just wild to think about.
It really is. We take the sheer mechanics of movement completely for granted. Like reaching for a coffee cup, it feels like a single, seamless thought, you know?
Oh, for sure.
But underneath that simple action is this massive, high-stakes negotiation between all these different regions of your brain. And in Parkinson's disease, that negotiation just completely breaks down.
Welcome to another deep dive. Today's mission is to totally reframe how you understand Parkinson's disease. We're looking at a stack of sources today that really strip away those surface-level symptoms, to explore the profound pathophysiology of this condition.
Yeah, we want to show you how this microscopic loss of dopamine neurons it cascades into a massive, life-altering movement disorder.
And this reframing is absolutely essential. I mean, we're talking about the second most common neurodegenerative disease on the planet here, right behind Alzheimer's. It affects, what, roughly 1% of people over the age of 60?
Yeah, about 1%. But to truly grasp the mechanics of it, you really have to look past the external shaking. You have to look deep into this tiny, very specific structure in the midbrain. It's called the substantia nigra.
Which literally translates to the black substance, right? Because these specific dopamine-producing cells are actually visibly dark under a microscope.
Exactly. They have this dark pigment.
But before we get to that microscopic level, we should probably look at how this disease was originally defined, because James Parkinson, he was really only looking at the surface, right? The posture, the walking. I mean, he didn't even run clinical trials.
No, not at all. So in 1817, he was this London apothecary surgeon, but he was also like a political radical advocating for social reform. Oh, wow, really?
Yeah, and a paleontology enthusiast, too. But he wrote this 66-page monograph called An Essay on the Shaking Palsy. And he built his entire thesis on just 6 cases.
Wait, 6 cases, that's it?
Just 6. And he literally just watched some of those men walking down the street.
You're kidding, he just watched them from the window.
Pretty much. I mean, he observed the stooped posture, the resting tremor, and what he called the festinating gait, that hurried, shuffling walk.
Right.
And he named the condition paralysis agitans. Now, he explicitly claimed there was no sensory or intellectual impairment.
Which we know now is totally wrong.
Yeah, it's incomplete. Cognitive decline and sensory loss are actually very common as the disease progresses. But for over 40 years, his essay, which was incredibly observant, was just largely ignored by the medical establishment.
Until Jean-Martin Charcot came along, right? The famous French neurologist working in Paris in the 1860s. He essentially rescued the text from obscurity.
Exactly. At the time, doctors were constantly confusing the condition with multiple sclerosis.
Ah.
So Charcot separated the two. He added rigidity to the list of defining features, and he officially named it Parkinson's disease, just as a tribute to the man who first categorized it.
So that historical definition, I mean, that really shaped how the disease is still recognized in a clinic today, right? With the TRAP acronym.
Yeah, TRAP. Neurologists look for this specific cluster of clinical symptoms. So you have tremor at rest, rigidity, akinesia or bradykinesia, which is this profound slowness and poverty of movement, and finally, postural instability.
But relying purely on those external symptoms, it creates this huge disconnect for the patient, I think. You look at a shaking hand and you immediately think, oh, the muscles are broken.
Right, which is completely understandable.
But to understand what is actually paralyzing these patients, we have to look at the machinery underneath all that. We have to dive into a set of structures deep in the brain called the basal ganglia.
Right. So think of the basal ganglia as the brain's board of directors for movement.
Okay, I like that. It basically decides when a movement should happen, how fast it should be, and when it needs to stop. And it does this by running 2 opposing pathways simultaneously.
The direct and indirect pathways.
Exactly. There's the direct pathway, which facilitates and encourages movement. That's your go signal. And then there's the indirect pathway, which actively suppresses movement, the stop signal.
So those 2 pathways are just constantly in tension with each other. And dopamine is the chemical that sort of tips the scales, right? It's released from that dark midbrain structure we mentioned earlier, the substantia nigra, and it travels into a receiving area called the striatum.
Right, the striatum.
And so dopamine basically acts like a volume knob, right? It turns up the go pathway and it turns down the stop pathway.
Yeah, it biases your entire brain toward initiating and sustaining movement.
Hmm.
But in Parkinson's disease, those specific neurons that produce and deliver that dopamine, they begin to die off.
And as they disappear, that volume knob just gets permanently stuck towards stop.
Exactly. The indirect pathway becomes wildly overactive. The brain becomes overwhelmingly biased against letting you move.
So the muscles themselves, like in the arm or the leg, they're actually perfectly fine.
Totally healthy.
It's like having a sports car with a pristine engine and fresh tires, but the ignition switch is completely destroyed. The muscles are constantly waiting for an authorization command that just never arrives from the basal ganglia.
That is a perfect analogy, and it perfectly explains why the primary symptom is slowness and a poverty of movement rather than actual, muscle paralysis. The machinery is completely intact, but the permission system is broken.
Wow.
But for a long time, the medical community didn't fully understand that dopamine loss was the singular driver of these symptoms.
Right.
To prove that dopamine loss alone causes this exact movement disorder, we actually have to look at this really tragic medical mystery from the early 1980s.
Oh, the story of the frozen addicts. This part of the sources was just mind-blowing. It completely shifted the trajectory of neurological research, didn't it?
It really did. So in Northern California, there was this cluster of young drug users, people in their 20s and 30s, who suddenly developed severe end-stage Parkinsonism.
Out of nowhere.
Completely out of nowhere. Within a matter of days of injecting a drug, they became entirely rigid. I mean, they couldn't speak, they couldn't move, they were practically frozen in place, showing all the classic clinical signs of late-stage Parkinson's.
Wait, so this bad batch of drugs, it just isolated the variable. It proved that if you only kill dopamine, you get Parkinson's instantly.
Precisely. A neurologist named J. William Langston investigated the cluster, and he traced the cause back to a botched batch of synthetic heroin.
Oh, man.
Yeah. The amateur chemist had accidentally contaminated the drug with a byproduct called MPTP. And when MPTP enters the bloodstream, it crosses the blood-brain barrier and is metabolized into this highly toxic compound called MPP plus T.
Okay.
And because MPP plus structurally resembles dopamine, the dopamine neurons in the substantia nigra readily absorb it. They just take it right in.
Like a Trojan horse.
Exactly like a Trojan horse. Once inside, the toxin shuts down the cell's mitochondria, their energy factories. So it selectively and rapidly massacres just the dopamine neurons.
I mean, it's a horrific tragedy for those young people, but scientifically, it provided the absolute definitive proof of causation, right?
Yes. Destroying those specific dopamine neurons perfectly mimics the clinical syndrome. And it also handed researchers the very animal models they still use today to test new drugs and study the disease.
But there is a critical difference here, right, between those young patients and someone developing Parkinson's naturally, because the synthetic drug wiped out the neurons in just a matter of days. In a typical patient, the death of these cells takes decades.
Right, it's a very slow burn. And because it happens so slowly, the brain does something incredible. It compensates.
Which leads us to one of the most counterintuitive facts in our sources, the 80% threshold.
Yeah, this is staggering.
By the time a patient goes to a neurologist with the tremor they've just noticed, they've typically already lost 50 to 70% of the dopaminergic neurons in their substantia nigra.
And the actual dopamine chemical levels in the striatum have plummeted by around 80%.
80%. That is just wild.
The brain is an extraordinarily adaptable organ, for years, maybe decades. As the neurons slowly die, the surviving cells are just working overtime. The brain upregulates its dopamine receptors, making them hypersensitive to whatever tiny amounts of dopamine are left.
It's aggressively rewiring the circuits just to keep you moving normally.
Exactly.
So you think to yourself, oh, my hand just started shaking. The disease is just beginning. But the truth is, the disease has been ravaging your midbrain for 20 years. The quote-unquote onset of symptoms is simply the exact moment your brain's buffering capacity finally collapses.
It simply runs out of tricks to hide the damage.
Wow. So knowing that the patient is already operating at a massive 80% deficit at the time of diagnosis, how has modern medicine attempted to fix that broken circuit?
Well, that effort gives us one of the most incredible bench-to-bedside arcs in neurology. In the late 1950s, this Swedish pharmacologist named Arvid Carlsson prove that dopamine wasn't just some chemical precursor, but a critical neurotransmitter in the brain.
He won a Nobel Prize for that discovery, right?
He did. And then in 1960, Ola Hornikiewicz took it a step further by examining the brains of deceased Parkinson's patients and proving their dopamine was severely depleted.
Okay, so they found the clean link.
Right. And those foundational discoveries paved the way for George Katsias in the late 1960s. He refined the dosing of a drug called levodopa, or LDAP.
Because you can't just give a patient a dopamine pill, right? Since dopamine itself cannot cross the blood-brain barrier.
Exactly. But LDAP is a precursor molecule that can slip right through the barrier, where the brain then naturally converts it into active dopamine. It totally transformed Parkinson's from a relentlessly paralyzing condition into something manageable. Bedridden patients were suddenly getting up and walking around.
It's almost like a miracle. But there's a major misconception here that definitely needs clearing up. Because a lot of people believe levodopa cures the disease, or that after a few years, the drug simply wears out and stops working.
Yeah, that's a very common misunderstanding.
Right, because levodopa doesn't cure anything. It just masks the symptoms by replacing the missing chemical. And the drug itself isn't failing over time, is it? The progressive nature of the disease is just changing how the brain handles the drug.
Yeah, think of the surviving dopamine neurons as little storage warehouses. In the early years of the disease, you take an LD-dopa pill. The warehouse neurons absorb it, convert it, store it in tiny vesicles, and slowly drip feed it into the brain.
So it provides a smooth, steady supply of that movement authorization.
Right. But as the disease progresses, those warehouse neurons continue to die off.
So you just lose your storage capacity.
Exactly. Without those storage cells to buffer the drug, the LDOPA floods directly into the brain all at once, causing these massive, uncontrollable spikes in dopamine. Oh, wow. So that's why the patient might experience dyskinesias, those involuntary rioting movements, because the GO pathway is suddenly wildly overstimulated.
Yes, and then, because there's no storage system to maintain it, the dopamine washes out rapidly, and the patient crashes right back into a rigid, frozen state.
The on-off fluctuations.
Yeah, it creates these brutal, severe on-off fluctuations that make managing the medication an absolute nightmare for later-stage patients.
But pharmacology isn't the only way we treat the circuit, right? When the drugs become too difficult to manage, surgeons turn to deep brain stimulation, or DBS. And this approach is purely electrophysiological.
Right. It was pioneered by a French neurosurgeon named Alim Louis Benabid in the late 1980s. So if you remember the basal ganglia circuitry, the stop pathway is wildly overactive because it's starved of dopamine.
Right. The volume knob is stuck on stop.
Exactly. Benabid discovered that if you surgically implant thin electrodes deep into a specific relay station of that overactive stop circuit, the subthalamic nucleus, you can deliver high-frequency electrical pulses to essentially jam the signal. So it acts almost like a pacemaker, but for the brain's motor circuit.
Very much so.
The sources detail how patients undergoing this surgery are often kept awake in the operating room, which sounds terrifying, but the surgeons test the electrodes in real time.
Yeah, you have a patient lying on the table, totally rigid, their hands shaking violently.
There.
The surgeon turns the electrical stimulator on, and literally within seconds, the tremor stops.
Like that.
Just like that. The patient's hand relaxes, and they can perform smooth, controlled movements.
I mean, it is the most direct, visceral demonstration that we are dealing with an electrical circuit imbalance here. The structural muscles are totally fine. The surgeons are just artificially correcting the flow of electrical traffic that the basal ganglia failed to manage.
It is truly miraculous to watch.
But, it forces a really obvious question. If the core problem is that we are missing dopamine-producing neurons, why are we jamming circuits with electricity? Why not just grow new dopamine cells and transplant them directly into the brain?
I mean, that logic seems flawless on a whiteboard, right? And in the 1980s and 1990s, researchers pursued exactly that.
Okay, so they tried it.
They did. They took fetal dopaminergic tissue and grafted it directly into the striatum of Parkinson's patients. And in the early open-label trials where everyone knew they were getting the treatment, the results looked incredibly promising. Patients really seemed to regain motor control.
But the rigorous follow-up tells a much darker story about how complex the brain actually is, doesn't it?
Yeah, it really does. When researchers finally moved to double-blind, placebo-controlled trials, meaning some patients received the actual fetal tissue transplant and others received a sham surgery where holes were drilled but no tissue was implanted, The results were devastating.
Oh, no.
Statistically, the transplant showed absolutely no overall benefit over the placebo.
None. But wait, for a subset of the patients, the outcome was actually worse than no benefit, right?
Much worse. The grafted cells survived and grew, but they didn't wire up with the brain's natural regulatory feedback loops. They just started blindly dumping dopamine into the system.
Oh, so they had no off switch.
None. These patients developed severe runaway dyskinesias. They couldn't control their flailing limbs at all, and because the tissue was permanently grafted into their brains, these involuntary movements couldn't simply be turned off by adjusting a medication dosage.
That is horrifying.
Yeah.
It remains this famous cautionary tale in neurosurgery. It proved that the brain isn't just a bucket where you can dump missing chemicals or cells. The spatial wiring, the feedback loops, the exact synaptic connections, they all matter.
They are critical, and it also reinforced the absolute necessity of placebo-controlled sham surgeries in neurological research. Human expectation can temporarily mask symptoms, but it cannot rewire a deteriorating brain circuit.
Okay, so we've established the mechanics of the dopamine circuit, how its failure destroys movement, and our varied attempts to fix it. But we still haven't answered the most fundamental question. If the disease is starting 20 years before the tremor, what is actually causing those dopamine neurons to die in the first place?
This is where modern neurology has experienced a massive paradigm shift. For over a century, Parkinson's was defined by where the damage was the substantia nigra. Today, it is defined by what the damage looks like on a cellular level.
Right.
And what it looks like is a protein gone completely rogue.
A protein called alpha-synuclein, right?
Yes. Alpha-synuclein is a normal, abundant protein found in perfectly healthy brains. But in Parkinson's patients, for reasons we are still trying to unravel, this protein misfolds.
Changes shape.
Right, it loses its functional shape and becomes sticky. And these misfolded proteins clump together inside the neurons, forming toxic aggregates known as Lewy bodies.
Which Friedrich Lewy actually first described way back in 1912, right?
Exactly. These clumps gum up the internal machinery of the cell, eventually killing it.
And this structural change really redefines the entire disease. It groups Parkinson's with conditions like dementia with Lewy bodies under this whole umbrella of synucleinopathies.
Yes, and it separates it entirely from Alzheimer's, which is driven by a different rogue protein called tau.
Right. And crucially, these Lewy bodies don't just magically appear in the midbrain the day before your hand starts to shake. There's a massive, multi-decade prodromal phase.
10 to 20 years of early warning signs that most people, and honestly even many general practitioners, would never associate with a brain disorder.
Like what?
Well, we are talking about a loss of the sense of smell, chronic constipation, severe depression and anxiety, and a very specific sleep disorder called REM sleep behavior disorder, where patients lose the natural paralysis of sleep and physically, often violently, act out their dreams.
So it's less like a fire suddenly spontaneously combusting in the brain and more like a line of falling dominoes. Which brings us to the Brake staging hypothesis.
Yeah, hi-go Brake.
Right. In 2003, Brake proposed this fascinating explanation for why those specific, bizarre early symptoms occur decades before the tremor.
Brake looked at autopsy data and suggested that the disease doesn't actually start in the brain at all. He proposed that the initial alpha-synuclein misfolding event happens in the peripheral nervous system, specifically in the gut or in the olfactory bulb in the nose.
Wait, the gut?
The gut. From there, the misfolded protein acts almost like a prion. It knocks into a healthy protein, causing it to misfold, which knocks into the next one. This toxic domino effect literally travels up the vagus nerve, which is the massive information highway connecting the digestive system to the brainstem.
And it takes years for this slow progression to finally ascend into the substantia nigra.
Exactly.
I mean, that perfectly explains the timeline. The gut gets damaged first, causing constipation. The olfactory bulb is hit early, causing a loss of smell. It takes a decade for the dominoes to finally reach the movement center.
It is an incredibly elegant model,
Yeah.
but subsequent autopsy studies have shown that biology is rarely that uniform.
Of course not.
Right. While many patients perfectly fit Brake's ascending model, a meaningful percentage of confirmed Parkinson's cases just do not. The Lewy bodies appear in their midbrain, but their vagus nerve and gut remain completely clear.
So that sparked a major modern debate because researchers like Per Borgermer are now proposing a divided model, right? Body first versus brain first Parkinson's.
Yes, exactly. In body-first patients, the dominoes start in the gut and work their way up, accompanied by that long history of constipation and sleep issues. But in brain-first patients, the misfolding event originates directly inside the brain itself, and the gut issues either happen much later or not at all.
And this realization fundamentally changes how we view the condition. Because researchers increasingly believe Parkinson's isn't a single uniform disease, it is a syndrome.
Right. It's a shared clinical endpoint, the death of dopamine neurons that different patients reach through entirely different pathways.
So what triggers the very first domino to fall? Whether it's in the gut or the brain, what causes that alpha-synuclein to misfold in the first place?
Well, this is where the battle between genetics and environment comes into play. On the genetic side, we have discovered rare mutations in genes like SNCA, LRRK2, and GBA.
Okay, and what do those do?
These genes basically act as blueprints. The SNCA gene, for instance, holds the instructions for making alpha-synuclein. A mutation can cause the cell to produce way too much of it, making clumping inevitable.
Right, just overwhelming the system.
Exactly. And other genes like LRRK2 and GBA are involved in the cell's waste disposal system, the lysosomes. If the genetic blueprint for the garbage disposal is broken, the cell can't clear out the misfolded proteins, and the Lewy bodies just accumulate.
Okay, so these rare mutations prove that Parkinson's can be entirely inherited. But the vast majority of cases are sporadic, right? There is no known genetic cause for most people.
That's right. And that places the spotlight squarely on environmental exposures.
Yeah, the sources heavily implicate long-term exposure to certain pesticides, specifically chemicals like paraquat and rotenone, as well as rural well water consumption.
Because these environmental toxins are known to cause mitochondrial dysfunction, it's actually very similar to how MPTP destroys the energy centers of the cell.
Oh, that makes total sense.
Yeah, and it's worth noting this is a massive battleground right now, both in science labs and in courtrooms, trying to untangle how much of a patient's risk is driven by exposure to industrial chemicals, how much is underlying genetic susceptibility, and how much is simply the cumulative wear and tear of aging.
Speaking of aging, I really want to shatter one last misconception before we wrap up, because many people assume Parkinson's is strictly a disease of the elderly.
Yeah, that's definitely a myth.
While age is the biggest risk factor, young-onset Parkinson's is a devastating reality for those diagnosed before age 50. Michael J. Fox was diagnosed at 29, Muhammad Ali at 42.
And whether a patient is 30 or 80, the tremor is rarely the most debilitating part.
Right. It's the non-motor symptoms,
Yeah.
right? The blood pressure drops, the anxiety, the eventual cognitive decline. That's what really robs them of their quality of life.
Absolutely. So what is the takeaway from all of this? We've learned that Parkinson's is this profound systemic failure of the brain's permission-granting system.
Yeah. It is defined by an 80% loss of dopamine, a microscopic devastation that operates in total silence for years before crossing that critical threshold.
And because our current treatments, from L-dopa to deep brain stimulation, only mask the symptoms of cells we have already lost, the absolute holy grail of modern neuroscience is neuroprotection.
We have to catch the dominoes while they're still falling in the gut, right? If researchers can validate biomarkers in that long prodromal phase, using gut biopsies, advanced smell tests, or sleep screening to detect the rogue alpha-synuclein early, we might one day deploy a therapy that clears the misfolded proteins before the dopamine neurons ever die.
We want to stop the disease before the patient ever experiences a single tremor.
It brings us right back to that effortless action we started with, reaching out to grab a cup of coffee. We take that complex neurological negotiation completely for granted until the dopamine runs dry.
We really do.
But based on everything we've unpacked today about where this disease might actually originate, here's a final thought for you to mull over. If the very earliest indicators of this devastating brain disease are chronic constipation and a loss of smell, decades before the basal ganglia fails,
Yeah.
is it possible that the medical pioneers who finally cure Parkinson's disease might not actually be neurologists, but gastroenterologists?